I'm Taylor Abel, I'm a surgeon. I focus on epilepsy surgery, and I'm also chief of neurosurgery at Children's Hospital of Pittsburgh. And they're going to give me this new adapter, which is going to work great. And I guess the other thing that I think is really important about my story is that I actually had epilepsy when I was a kid. So I had benign Rolandic epilepsy of childhood, which thankfully is something that I grew out of when I think I was in 4th grade. But that was part of the reason I got into doing epilepsy surgery. I thought that I was going to be a neurologist, but it just turns out that neurosurgery was a great fit for me, and I ended up being a neurosurgeon. Are my slides showing up now? Okay, great. So this is a picture of our children's hospital, and look, I've got some slides, and they're going to kind of take us through this discussion of neuromodulation for epilepsy, meaning using ways of changing the brain's activity to treat seizures. But this can be really informal. If you want to stop me and ask a question, like, that's fine. My goal is to not have this take up the whole, I think, 45 minutes. And just to answer as many questions as you'll have. I mean, this is a pretty small group, so I don't want anybody to leave with questions. So on that note, let's get started. These are my disclosures. Don't try to memorize the slides. Ask questions. We're gonna have plenty of time. You can even, if something's not clear after this talk, send me an email. My patients have figured out that you can Google my name and find my email address, and I don't mind that at all. Feel free to ask me questions. So I'm going to talk about what neuromodulation is. I'm going to talk about different types of neuromodulation and how they're used in epilepsy. We're going to talk a little bit about using different neuromodulation strategies together. We're going to talk about combining traditional forms of surgery, like resective neurosurgery and neuromodulation. And we're also going to talk a little bit about how to make decisions. First thing I want to talk about, though, is when should you consider neuromodulation? And this is a paper that was recently published by the Surgical Therapies Commissions of the International League Against Epilepsy. And this is a bunch of experts, epilepsy experts, who got together and decided and thought about when should we start thinking about surgery. And the conclusion of this is that if you're on 2 appropriate medicines and you're still having seizures, you should be thinking about some treatment other than medicine. And the reason for that is because the probability of becoming seizure-free on an additional appropriate medicine is 5 to 8%. So once you get to this point where you have what's termed drug-resistant epilepsy, your probability of becoming seizure-free with more medical treatment is really low. And that's why that's when you should be referred to an epilepsy center that has experience with epilepsy surgery, but also has experience with neuromodulation. And the reason why neuromodulation in our current era is really a game changer is because it used to be that we only had epilepsy surgery options for people who had certain types of epilepsies. But with neuromodulation, there are more types of epilepsies that we can treat to reduce the burden of the illness. I'm going to start by talking about one of the most common types of neuromodulation called vagus nerve stimulation. Raise your hand if you've heard of vagus nerve stimulation. All right, everybody in the room. And so it's really common. And this is what it looks like. And so it's a procedure where we are stimulating the vagus nerve, implanting a device that stimulates the vagus nerve, that with the idea that this is going to change brain activity to reduce seizures. And I think one of the biggest advantages is that it overcomes the stigma of brain surgery. So I think just the idea of having brain surgery can be really overpowering sometimes. And there are more seats up here if anybody wants to sit down. But vagus nerve stimulation is quote, not brain surgery. It's a stimulator in the neck. It has a low complication rate, so it's safe. Patients come into the hospital to have surgery. They leave the same day. One of the most common complications of the surgery is infection. So there's about a 3 to 5% risk of infection with the procedure. And we do things, and other surgeons do things to really reduce the rate of infection, like give antibiotics and treat with antibiotics around the time of surgery. There's a lot of papers about the effectiveness of vagus nerve stimulation. And a lot of times when we're using vagus nerve stimulation, we're using it for individuals who have seizures. And so it can be difficult to count the seizures. And so it's difficult sometimes to measure the outcomes of neuromodulation strategies like VNS. But in general, the way we think about it is we think it's a successful outcome if you think the frequency of your seizures have been reduced in half. And so with vagus nerve stimulation, we think about half of people, or a little bit more than half of people who have vagus nerve stimulation, their frequency is reduced in half. But you can see here from all these different papers that have been published that there really are a range of outcomes that are reported in the literature, but in general, that's kind of what we think. But what's really important to note is that there's an emerging literature that shows that individuals who have vagus nerve stimulation have a reduced risk of what's called epilepsy-related mortality, so death caused by epilepsy. And so these treatments may increase survival in epilepsy and increase the safety of epilepsy. So I know that that's a really difficult thing to talk about, but it's an important thing to know that there's this emerging literature that shows that VNS may increase the safety of heavy epilepsy. One thing I think is really important to mention is that in many individuals with epilepsy who are considering VNS, we are often, particularly in a type of epilepsy called Lennox-Gastaut type epilepsy, we're often considering vagus nerve stimulation along with other treatments. And individuals with Lennox-Gastaut type epilepsy, they often have a lot of drop seizures. These are atonic or tonic seizures where you suddenly have a seizure and fall over. And it's really important to think about these seizures when we're thinking about how to treat epilepsy, because these seizures can cause a lot of injuries. And so oftentimes in these, I'm going to say children and young adults because that's who I take care of, but in children and young adults with these types of drop seizures, we're often considering vagus nerve stimulation or corpus callosotomy. And it's important to note that corpus callosotomy can be a really difficult thing to consider because it involves doing a procedure to actually disconnect one of the really important connections in the brain. But what's important to note is that corpus callosotomy is one of the most effective treatments we have for drop seizures. And so I often will encourage families to think about it and talk with families about the pros and the cons, but also acknowledging that VNS can also be very effective. And this is just a paper, we don't have to go through all this data, but this is a really well-done paper that compared the effectiveness of VNS and corpus callosotomy in all of these different papers that have been published at the time that this came out. And what's really important is that we can also do these procedures like corpus callosotomy through much less invasive approaches than what used to be required. So it used to be that when corpus callosotomy was first invented back in the 1950s, do you have a question?
What is a corpus callosotomy?
Great question. So actually, why don't I go over that right now? Corpus callosotomy is a procedure where in individuals who have drop seizures, where they have seizures that spread really fast and they fall over and can hit their head, we do a procedure where we disconnect one of the connective fibers in the brain called the corpus callosum. And it's something that's been around since the 1950s, and it's one of the most effective treatments for drop seizures. But traditionally what it involves is doing a larger incision on the head, where a surgeon will then go in, make a window in the bone, and actually go into the microscope and actually disconnect the corpus callosum directly. But the way we're able to do it now is we actually just place these small laser fibers into the brain, and we can actually do a corpus callosotomy with these really small lasers and actually completely avoid doing an incision. And so I just wanted to show this to illustrate that even though with these bigger brain surgeries, we used to have to do large incisions and large craniotomies, we're now able to do these procedures with similar effectiveness, which is what this slide shows, through these smaller approaches just with small lasers. Not everyone is a candidate for this procedure, and there are different pros and cons, so it's important to talk with your team if you're considering anything like this. But even though this talks about neuromodulation, I want to make sure that everyone knows that this is also an option. And if you go to a center that only performs one type of thing, they only do corpus callosotomy or they only do VNS, you should consider going somewhere that does both so you can really talk about the pros and cons and know what all your options are. Any other questions about that?
When you talk about the outcomes in terms of potential side effects or negative effects or
Yeah, I will. This is a great question. So one of the big downsides of corpus callosotomy is that after the procedure, some kids and young adults, and I think it probably is a little bit more pronounced the older you are, will have something called a disconnection syndrome. The literature quotes that about 14% of individuals that have a corpus callosotomy will have this disconnection syndrome. But what it is for about 3 months, someone's personality can be very blunted. Someone who has a corpus callosotomy will sit around and not move as much. And eventually this will get better, but it can be really difficult to get through. And oftentimes individuals with corpus callosotomy, whether it's done in a traditional approach or whether it's done with the laser, will have this disconnection syndrome. So even though these surgeries are done through smaller, less invasive approaches, they're still big surgeries that can require a lot of rehabilitation. So that's a great question. Any other questions? Yes? So the question is, when we say disconnection, what do we refer to? And what disconnection refers to is, it just refers to the disconnection of the corpus callosum, and that there is this syndrome associated with doing that is generally temporary, but will get better over time. Generally, what I'll tell families is, this is even though the surgery is very effective, it is very difficult to get through, and you are going to hate me and regret doing this for 3 months. And I try to meet with families multiple times before doing a corpus callosotomy, just so that they trust me and that they know that we've talked about how these 3 months are going to be really tough. But then after that, generally, my kids will come back to clinic and they're more awake. I sometimes even have kids that after 3 months are on fewer medications. They're not having the drop seizures anymore, and so it can really help with quality of life. Any other questions right now? Go ahead, yeah.
So is that only for people exclusively having drop seizures, or does it also show a reduction in other types of seizures?
Great question. So if we go back and look at the Lankman study, it does help with other seizure types. So you can see it helps with generalized tonic-clonic seizures. It can even help with complex partial seizures. So there's an effectiveness level with just about every seizure type. But really it's most effective for drop seizures, where for atonic seizures, right here you see that 80% effectiveness rate at cutting the seizures in half. And so it's most effective with atonic.
And how young how young patients do you use this for?
I think the youngest I've personally done, I don't think there's necessarily an age cutoff. The youngest I've personally done is maybe a year of life.
Any type of, like, the sooner it gets done, the more brain elasticity you see, or does that not matter for this?
I do think in general, my experience is that when I've done this procedure in younger kids, they tend to bounce back quicker. And I think of it just by thinking of the kids that are younger than 10 and the kids that are teenagers, or I've even done this procedure in young adults, they seem to bounce back quicker when they're younger. But I would say everyone I've done this in has generally bounced back pretty well, with few exceptions. Any other questions? Yes.
What does like that 3-month recovery process look like? Are there like therapies that you recommend or other things?
Great question. Yes. So generally, the way we do it at Pittsburgh is there's rehabilitation, which is after the surgery. You can work on therapies and things, but we have what we call prehabilitation, where before you even have the surgery, you come to our epilepsy clinic and you meet with a rehab doctor and a neurosurgeon and a neurologist and actually a neuropsychologist. And we all get together. I'll talk about the surgery. The neurologist will talk about other available treatments. But then the neuropsychologist and the rehab doc will talk about the rehab that we're going to do both before and after the procedure, just to optimize the outcome. A lot of times in epilepsy surgery, we get hyper-focused on making seizures better, and we forget that making the seizures better is the goal of that is to get quality of life better. And so we try to think about things holistically, and so a lot of times after corpus callosotomy, we're trying to get kids into an inpatient rehab, and even young adults and older adults, this can be even more important, so that we're working on physical therapy, occupational therapy, rehabilitation therapy, to get them back up, walking, moving around, doing the things they were doing in their daily lives as soon as we can after surgery to really optimize the outcome. So definitely all those things are play a really big role in this. There was another question.
Well, I was just had a comment. Our son was 4 when he had it done. And I'm glad you mentioned that 3-month period because they didn't let us know that. And I remember after surgery, I was crying because it was bad. He was there 21 days. We had him during COVID. There was only one parent allowed in the hospital.
Yeah.
And he was a person that they always said he wasn't a candidate for, but we got a different neurologist. And she chose that he was a candidate. And we did it for quality of life on him, because he has total care. And he did get more alert. His seizures did decrease, but that 3-month period was rough.
Yeah.
And I'm glad you mentioned it to parents, because that is rough when they have that. Yeah.
To be honest,
Yeah.
it's hard whether we tell you about it before surgery or not.
Yeah.
It's tough to get through that period where you're recovering from the surgery, but it's a really effective treatment. Go ahead.
Same thing with a comment. That's what we chose not to do. He's 36 now. He's about 30? 32-ish. So it was right after COVID, more or less. And that was one of the things they talked about doing. And she said the risk was 50-50. And losing personality,
But she never told us the numbers.
and she never told us anything about the recovery being tough. And we were just thinking, okay, wait, if something went wrong, we're gonna lose his personality, his laughter, and all that other stuff.
And if you know now it's 3 months, maybe we should, okay.
Yeah,
But
I
then
think
was
I
it
think
never right?
every situation's a little bit different, but in general, personality is something that bounces back. In general, I also think that these are things that our field is still sorting out. I mean, I think one thing I've been telling myself that I want to do for the last year and a half is do a study where we call families that have had corpus callosotomy 5, 10, 15 years ago and say, do you regret having surgery or not? And I think that's a study that has not been done, but would be really important to do, because a lot of what I'm telling you right now is based on the experience of someone who talks a lot with families that have a lot of these surgeries, because we do a lot of these surgeries. But we need systematic and rigorous evidence that I think tells us the patient's perspective on what it's like to have these surgeries done. That's something that I think is still missing that we really need. Yes?
Corpus callosotomy, as far as easy to lateralize and do through stuff, do you see that as a common thing that you're recommending?
I think people are doing it. We have done it rarely. there are some teams that have really published on it and have talked about doing that a lot, and so it is a thing, but it's not. I would say it's not very common, and I think if you're going to have something like that, you want to do it with a really experienced team.
Sorry, any long-term functional deficits of corpus callosum?
This is a great question. I think there can be. So you can have like a long-term disconnection syndrome where your brain, the hemisphere's abilities to really communicate and do more complicated things long-term may be affected. I think that this is difficult to, it is not really well studied because most of the time when we're doing a corpus callosotomy, it's in kids and young adults who have some impairment before they have the procedure. It's pretty rare that I have done this procedure in kids, say, that are in like college. And a lot of times we're thinking about other procedures in kids that have like full language abilities and things like that, just because there is a risk of having some language impairment after a corpus callosotomy.
Well, my question wasn't about that, but on this, so my daughter's going to be getting the VNS next month.
Yeah.
She already went through all the phase 1 testing, and I was just curious, like, the difference. Is there, like, certain types of epilepsy? If you get VNS or the DBS or the RNS, like, how do they decide which device they feel would be the best for your child?
Let's keep moving forward.
Okay.
Yeah, so we are going to talk about DBS and RNS in our next like 20 minutes or so. I think a lot of times, though, given the level of evidence that we have for these different things, a lot of times it's the experience of the center. So, like when I came to Pittsburgh 6 years ago. Okay. When I came to Pittsburgh 6 years ago, we were like a VNS center.
She used to go to Pittsburgh.
Okay, yeah. So we were doing 25 to 50 VNS procedures a year, and over time we've just kind of evolved and done some different things, and I'll kind of talk a little bit about that in the coming slides. But I think there are no what are called comparative effectiveness studies that compare the effectiveness of these different treatments to each other, and these studies would be really difficult to do and really difficult to fund. And so it's really difficult to actually have that knowledge of what's best in what situation. And so a lot of times what centers do is they err on the side of their experience, and they also use shared decision making where you're talking about the pros and the cons, and they're making a decision together with the family.
Yeah, I meet with them on next month before the surgery, but I was just curious.
So deep brain stimulation has also been around for a really long time. And neurosurgeons have a lot of experience using deep brain stimulation for movement disorders. And these are when we're taking stimulator electrode leads and implanting them into subcortical structures in the brain, meaning beneath the cortex. We often use stereotactic targeting, and some groups like ours use a robot to put these electrodes in. And this slide is just to illustrate that there are these different parts of the brain where we place these electrodes, and different groups are still trying to figure out the effectiveness of placing the electrodes in these different areas. But one of the most common for generalized epilepsy, Lennox-Gastaut type epilepsy, is the central median nucleus of the thalamus. And this is a recent clinical trial that the Australians put together, the ESTIL trial, which used central median DBS in young adults with Lennox-Gastaut type epilepsy. And it showed the efficacy, because this is a clinical trial, we're talking about efficacy rather than effectiveness, of using central median DBS, comparing it to people who had the device placed but it wasn't turned on yet. And so this is one of the highest levels of evidence that we can get, but it's important to note that these trials are really difficult to do, they're really expensive, and it's even tough to get things like NIH and the Brain Initiative to fund things like this, because when you implant a device in someone, particularly in a child, you have to have insurance for that device for the child for the rest of their life after they're in the clinical trial. So these clinical trials can be really expensive to do. And so sometimes families will say to me, but there's no clinical trial that shows what you're about to do with my child. And sometimes the answer is, well, there may never be. You know, we've been using vagus nerve stimulation for many years, and for a lot of the things that we use it for, there has never been a clinical trial, and there probably never will be, just because of how expensive and difficult it would be to do it, even though that would be the way to get the highest level of evidence. So I'm going to talk about, so a lot of times I'll have a child with Lennox Gastaut who comes to my clinic, and we will have a discussion about VNS and DBS. And the way that conversation goes is I'll just talk about the pros and cons of each of these treatments. I'll often tell families that the vagus nerve stimulator, I'll kind of go over the different rates of effectiveness, which maybe DBS is a little bit more effective, but we've never had a direct comparative effectiveness study like we talked about. But then I'll talk about other things that are trade-offs for these procedures. For example, because there are a lot of deep brain stimulator companies and they all compete with each other, the technology is great. So they've got rechargeable batteries. And those pulse generators, those batteries can last like 15 years, which we've actually shown every time you do a battery change, the risk of infection after vagus nerve stimulation gets a little bit higher. And so if you have a rechargeable battery that lasts for 15 years, that may be safer in the long term than having to change the battery out every 5 years. And so there are these different trade-offs. They have different programmers. There's a trade-off with there's a small risk of bleeding in the brain when you have a DBS placed. And so there are these different trade-offs that we talk about, but we don't have any direct studies that compare those two technologies. I'm going to talk about RNS for a little bit, and we'll hopefully have some time for questions. So responsive neurostimulation, this is a schematic of what it looks like. And so you're actually, the pulse generator gets implanted in a small window in the skull, just like you see here. And then it can be connected to a depth electrode or a cortical strip electrode that goes on the surface of the brain. And you need a pulse generator revision every 8 to 10 years. So the batteries last for a long time. And traditionally, the electrodes are placed over the cortical origin of the seizures. So you have, the idea is you have this idea of where the seizures come from, but either it's a part of the brain that you can't remove because it's too big, or there are really important functions in that part of the brain. And so rather than removing that part of the brain, you're going to place these electrodes on it. And these electrodes will sense when seizures are occurring after a period of time, and then you deliver a therapeutic stimulation in response to sensing the seizures. And this is a 9-year prospective efficacy study on efficacy and safety of responsive neurostimulation for focal epilepsy. You can see that the median change in seizure frequency gets better over time with this technology, and this can be very effective. Bitemporal, oh, go ahead, there's a question, go ahead.
You say the RNS is placed on the cortical surface. Have you ever placed the electrodes into the thalamus?
I'm going to go over that actually in this slide right here. We're going to go over it. And actually, let's go there right now. So originally, people were thinking about RNS as a treatment for focal epilepsy. So with the idea being that epilepsy is on the cortical surface, figure out where it is, put the electrode on the cortical surface where you think the seizures are coming from. But because RNS has this advantage over DBS in that you can actually detect biomarkers of seizures from the neural signature, some groups began thinking, well, why don't we place these RNS devices into deep brain structures like the thalamus? And so this is an example of one of the first times we did this in a child. This is the centromedian nucleus that you can see here, and these are 3D reconstructions of the centromedian nucleus. You can see the electrodes going in there, and then hooked up to a pulse generator in the same way. And we found that this, for certain types of generalized epilepsies, particularly our experience has been primary generalized epilepsies, this has been quite effective. Now again, we're waiting for the results of clinical trials that are ongoing right now. There's one clinical trial for Lennox Gastaut, RNS and Lennox Gastaut type epilepsy, for RNS in primary generalized epilepsy. We're waiting for the results of those clinical trials. But our experience in doing this has been that in certain patients, it's been very effective. We've had anecdotes of some kids even becoming seizure-free. Those are rare, but we've seen it. The other thing I was going to talk about is that because of the recording capability of RNS, it helps us in other ways other than just therapeutics. And so in bitemporal epilepsy, we've learned over the years that you can't remove both temporal lobes. There's actually a really famous patient named HM who had both of their temporal lobes removed years ago, and we learned from that patient, meaning the field of neurosurgery and neuropsychology, that if both temporal lobes are removed, that you can no longer form memories. And so in bitemporal epilepsy, because we can't remove both temporal lobes, we can place electrodes in both temporal lobes. And so RNS is a way of doing that, where we can actually place an electrode in each hippocampus, which is the center part of the temporal lobe, and record and stimulate in response to seizures. And the secondary benefit of doing that is that you can begin to determine the proportion of seizures that come from each temporal lobe. And so if you record for over a year or so, you may see that 90% of the seizures come from one side, and that may give you an opportunity to go back and actually remove that side, which is clearly worse than the other. And there's some evidence that in doing that, in some cases, you can actually become seizure-free or certainly have a higher odds of seizure freedom. We've also in our group have used responsive neurostimulation as a way of monitoring someone's progress with their epilepsy. Are seizures becoming more frequent? Are seizures becoming less frequent? How are things changing with the addition or subtraction of different medicines? And so RNS gives us a way of monitoring someone's seizure frequency. These are different RNS targets that have been used: central median nucleus, anterior thalamic nucleus. The pulvinar nucleus is becoming a more popular. And these are just different parts of the brain that have different rationale for stimulation of different types of epilepsy. I want to talk a little bit about combining different neuromodulation procedures. This is a study that showed combinations in really small numbers of patients early on, showing combinations of RNS and VNS and DBS and VNS, really just to show that this is safe and that there can be incremental value in adding one neuromodulation strategy on top of another. But I think a more recent study that I think is important is this advanced study that George Ibrahim at the Hospital for Sick Children in Toronto led, where they did add-on deep brain stimulation and compared it to continued vagus nerve stimulation for childhood epilepsy. And so this is what's called a pragmatic clinical trial. So it's a clinical trial, but it's a clinical trial that's based on an individual or family's choice. And so this study took patients that wanted to just have VNS and then compared them to patients that had VNS but wanted to add on deep brain stimulation on top of it. And what this showed is that having DBS in addition to VNS was more effective than just continuing with VNS. And so this is an important study that was recently completed.
Taylor, you have
Yes.
a question here.
Oh yeah,
So I was gonna say, do you leave both devices on? You have the VNS running and the deep brain stimulation running, or is it?
Yes and no. So I have, I'll tell you about a conversation I had last week with one of my families where they had a VNS, and then the VNS didn't seem to make a difference, so we did a RNS. And unfortunately, the RNS got infected, which is pretty uncommon, but it happens. Can't with anything. And the mom told me, I had to talk to mom, if this infection was, we did not not have to remove the RNS in this case, but the mom said, you can remove my child's VNS, but you better not ever remove my child's RNS. So the first thing we have to talk about is how much do we think the device is actually doing? I have families that are just convinced that their device is not doing anything. And if it's not doing anything, if it's not causing any problems, I would generally just turn it off and leave it there. Because the other thing I tell families, I think any surgeon in this room would tell a family this, it is way tougher to remove a VNS than it is to put one in, and a lot higher risk.
So you do turn the device off and then
We
use
can.
the DBS?
Yeah.
You don't run them simultaneously?
But you can run them simultaneously too. And there's another group of families that think that each device has incremental value. And so they're both doing something, even though they may be a little bit different. Go ahead.
That's his game plan now. He just got the RNS
Okay.
a month ago.
And for me as a parent, I feel safe that maybe whatever RNS is not doing, VNS is doing, so I feel comfortable with both of them being on it
Yeah.
myself.
Yeah, I'd say most families were keeping both of them turned on unless there's a reason to turn it off. Like side effects or something like that.
Another question.
Oh, yeah.
Do you think VNS or RNS, like, I know everything is probably case by case, but for kids that have generalized epilepsy? Because my daughter she's just diagnosed with intractable generalized epilepsy.
I have intractable generalized epilepsy.
I think this is something that if you got 100 neurologists and epilepsy surgeons in a room, they would debate this. And so I don't think it's really known. Because nobody's ever done a study.
Well, this question was that one slide said, generalized epilepsy, and she's getting VNS, so that's why.
Yeah, I think at our center, for generalized non-symptomatic, meaning you get the MRI looks normal, there's a presumed genetic cause of the generalized epilepsy, we would probably do RNS or VNS at our center, depending on what the family's comfort level
Yeah,
is.
she did genetics, and she has actually Pitt-Hopkins syndrome, so that's why I'm just curious.
Yeah.
One's better than the other.
Yeah, I think people would really debate that.
Another question here.
Wait, yes.
Oh yeah, I have generalized epilepsy, and actually having the VNS, it's more of a comment going off of what she said. Having the VNS has greatly reduced the severity of my seizures.
That's awesome. That's great.
I wanted you to have that reassurance.
Thank you, I
Yeah.
appreciate that.
That is great. So yeah, VNS reduced her seizures. That is awesome.
Another one. All right. I don't know if this is like the full question portion yet, but if a patient has already had 2 brain surgeries, a functional and then an anatomic hysterectomy, and VNS is the next thing our neurosurgeon is considering, but the risks of opening up the skull multiple times, hydrocephalus, and the skull portion not getting blood flow back to it. Do you ever like default to putting in a shunt or a replacing the skull fragment while you're already in there giving the VNS?
So actually, thankfully for VNS, you would not have to reopen the skull because VNS would just be going into the neck. The VNS.
Okay.
Are you talking about VNS or RNS?
Sorry, the one that's in the RNS. Sorry, RNS.
Okay, sorry. Okay.
Okay.
So I think, well, this is getting into the weeds, and this is like just my neurosurgical opinion here. Generally, though, unless there was like an infection or something like that, we would just try to use the native bone. Because especially in someone young, there's a good chance it's going to heal into the adjacent bone and all of that. So maybe you just put the RNS somewhere around there and remove a little area bone there, put the RNS in. Yeah. So I would not replace it just because you're in there, but surgeons might do it differently, and your surgeon certainly would know more about your child than me.
Right, because you have to go back in 5 years anyway. Every 5 years to replace the battery. Is that what you were saying?
Every 8 to 10.
8 to 10.
And in fact, I think at one point there was some evidence that they last even longer than people thought. And
I think the VNS is every 5 years.
yeah, the VNS is the one that doesn't last quite as long. Does that answer your question?
Depends on the setting.
Other question?
Previous physician I was speaking talked about doing an SEEG prior to doing one of the neuromodulations. Like, what's the frequency, I guess, in your practice that you see that you're doing that? Like, doing an SEEG, specifically just referred to the ophthalmic RNS.
Yeah.
I do that in your
Yeah, great question. I think this is something that is very debated in the field. And if you were to see 10 different talks on that topic, you would probably hear 10 different things. In our practice in Pittsburgh, we end up doing invasive monitoring, meaning the SEG, before we place stimulators at cortical sites. But we generally are not doing a lot of what's called thalamic SEG, just because there's a little bit more debate about the value of doing thalamic SEG, and so that's something our field is talking a lot about right now. Yeah. Other?
Oh, I have another question.
Oh, yeah.
Sorry, no, your study where it talks about doing a neuromodulation by focal epilepsy, doing the device versus like a resection, is that often due to the motor or language component? That's a procedure full time. That's why you're treating focal epilepsy with neuromodulation.
I think, yeah, to summarize your question, the question is how do we decide between resection or neuromodulation in focal epilepsy? If we can do a resection and it's safe to do it, that's, I think, what we would try to do, because the effectiveness of a resection, if we have a good idea of where the seizures are coming from, is so much greater than neuromodulation. Neuromodulation can be a backup option, and we can go back in and do some neuromodulation around our resection if it's close to motor or language or something like that. But if we can do a resection, we generally try to.
Yeah, so this is the study close enough talks about being specifically focal.
Yeah, focal epilepsy when we cannot do a resection. Yeah. Because it used to be that if focal epilepsy was coming from the part of the brain that was responsible for language, we just would not remove that. Yeah, in a lot of cases. So I thought we have 2 minutes left. We've talked a little bit about how to make decisions. Generally, shared decision making can be really important. Talking about the pros and cons. Going somewhere where all the options are available, and really discussing the pros and cons of different options. We need more clinical trials. We need more comparative effectiveness studies. And the best strategy is not always known, so the pros and cons of each approach should be considered. We kind of ran out of time, and I'm really sorry about that. Are there any questions with our 2 minutes left?
Outside of the clinical trial, the RNS and the generalized, is that still going on? Like, my son's supposed to have an RNS and generalized, since he has LGS.
Yeah.
At the beginning of the year, going into the balance.
Yeah. So a lot of centers are doing a lot of that right now while we await the results of the clinical trial. And so the clinical trial results probably won't be here the next year, I would guess. I don't know, I'm not part of the trial, but those results will be really important for us to know, like, the way forward for Lennox-Gastaut and RNS.
Yeah.
Or, what's that?
He has a VNS already.
Yeah, yeah. But that's another example of, actually, we don't have great clinical trials for VNS and Lennox-Gastaut either. Even though it's one of those, we have tons of observational data, like meaning non-clinical trial data, but we do it because we don't have other great options. And it can be effective according to the data we do have.
We can squeeze in 6 more minutes.
Okay, all right, everybody ready for 6 more minutes? Yeah. All right, we got a question.
You had data earlier about VNS with the corpus callosotomy. Is
Yeah.
there more data coming out with the corpus callosotomy in VNS or RNS?
In RNS, I think the way you would I think when there is more evidence, someone will probably do a systematic review where they take all the data for RNS and all the data for callosotomy and then compare them together in a systematic review. Because I doubt anyone will ever do a direct head-to-head study that compares those things. There will probably be some evidence from the LGS clinical trial about the effectiveness of RNS for drop seizures, and that would be really helpful. But it'll be years before we have this amount of data to compare those two things.
So if you're looking into, you're looking at these surgeries, if you have a child who's very active in the sports, which one would you suggest?
Great question. I think there are pros and cons of different approaches. I think one thing I would think about is with any of these neuromodulation strategies, if you're playing sports, the leads can become damaged, and so maybe having a device with shorter leads, like VNS, maybe there'd be some advantages to doing that. Though I have kids with deep brain stimulators that play sports. In fact, I have a kid I take care of who has terrible dystonia and couldn't play sports until they had a deep brain stimulator. And so the rep keeps telling him, don't play sports, you're not supposed to. It's like, well, why do we have this device? That's why we're doing this. And if the leads get broken, we'll repair them. And it'll be worth it because you're playing soccer. I think I'd be a little bit more cautious with the RNS in kids that are really active with sports and like playing soccer and things, just because part of the skull is replaced by the device. But I think you just have to talk about the trade-offs and when you're considering activities. Any other questions?
How about just wearing a helmet? Would that help? A helmet or some kind of, if you're playing sports?
Yeah, for sure. I mean, John Olerud, who was the first baseman for the Seattle Mariners, he had a big meningioma resected and had to wear a helmet when he was playing first base because he had a titanium plate over his skull, but he was a professional baseball player. I think you can work on adaptations with your team and with your rehab doctors, and it's just something you really have to think carefully about and consider when you're going over all this stuff.
When I first had my VNS installed, I had my ecology class. They asked how I could. They just had me stay away from the water because I was still in an active scarring phase.
Yeah.
But they still let me participate in the class. They still let me touch the stingrays.
That's awesome. Any other questions? Thank you all so much for your attention.